Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. All right, so our next patient today is going to be a 58-year-old postmenopausal woman with a history of stage 2A invasive ductal carcinoma, ER/PR positive, HER2 negative. She's status post right lumpectomy and axillary lymph node dissection. She's also received adjuvant chemotherapy, radiation, and adjuvant endocrine therapy with letrozole in 2010. Now, 10 years later, she presents with diffuse osseous metastatic disease, and we're going to be discussing her management. So as I mentioned, she is 58 years old and postmenopausal, but she also has a history of polio and resultant deformities resulting in a need for use of a wheelchair. In 2010, as I mentioned, she was diagnosed with an invasive ductal carcinoma. That was a T1C tumor, N1A, estrogen and progesterone receptor positive, HER2 negative. Her right lumpectomy and axillary lymph node dissection was completed, and then she received adjuvant chemotherapy with fluorouracil, epirubicin, and cyclophosphamide for 3 cycles, followed by docetaxel for 3 cycles. She subsequently received radiation therapy, 50 gray and 25 fractions. She then transitioned or started on exemestane, which was then later changed to letrozole. Unfortunately, she was lost to follow-up due to socioeconomic factors and loss of insurance, and her ECOG functional status is 2. So Dr. Jockelson, I'll have you maybe walk us through some of her imaging findings.
Okay, and so this is an example of what her right breast probably looked like. I don't have her own images, but I used it as an opportunity to show you all contrast enhanced mammography, which is something that is one of my main research interests, but also really a good way of looking at the breast and actually staging breast cancer within the breast that is equivalent to that of using MRI with fewer false positives. So you can see that she has an irregular mass in the lower inner quadrant of her right breast. And these are the contrast images, and you can see that the tumor enhances. And it's been demonstrated to show the size of the tumor more accurately than all other imaging exams, and again, to be equivalent to MRI in staging of the breast cancer, and the cost is 10% that of doing an MRI. So she then presented with a pulmonary embolism, something that we certainly can see as a spontaneous occurrence in a patient with adenocarcinoma of some or any kind of cancer. And just to show that she does have the embolism, but at the time of the CT scan of the chest, they also demonstrated that she had metastatic disease to her spine. And so she had a PET scan, which demonstrated multiple areas of hypermetabolic activity and abnormalities. And interestingly, in her real life, she also had a biopsy of this FDG avid left iliac metastasis to confirm that this was, in fact, metastatic breast cancer.
Perfect. Thank you so much for that. So she was subsequently started on palbociclib, fulvestrant, and zoledronic acid. Dr. Hurvitz, do you want to comment about that? Would that have been your choice of therapy, or is there anything you would like to add to that?
Well, first of all, I'm assuming she had a biopsy to establish that this is indeed a metastatic breast cancer with a recurrence.
I showed that. Yeah.
Yes. Thank you for pointing that out. The importance of the confirmation of stage 4 disease and the confirmation of the prognostic markers. I failed to mention that, yes, that was completed and was consistent with her original tumor diagnosis.
Excellent. So I think zoledronic acid or Pamidronate, a bisphosphonate, is certainly indicated given her bone metastases. Frontline use of a CDK4/6 inhibitor is standard of care. Palbociclib was the first one to demonstrate efficacy in this setting and was accelerated approval in 2015, but we now have a total of 3. In the frontline setting, the Paloma 2 clinical trial, which looks at palbociclib with an AI, did demonstrate a near doubling in the progression-free survival by adding palbociclib to an AI. We don't yet have overall survival data from that clinical trial. We do have in the second line setting, which hers would be because she recurred on an AI, so she would be we wouldn't be using an AI, we would pair it with fulvestrant as this clinician has done in this particular case. The Paloma 3 study, which combined palbociclib with fulvestrant, again improved progression-free survival, but not overall survival in the intent to treat population. Ribociclib combined with fulvestrant did demonstrate an overall survival benefit in the Mona Lisa 3 study, and abemaciclib plus fulvestrant demonstrated an overall survival benefit in the Monarch 2 trial in this setting. So all 3 show similar PFS benefits. There are slight differences in their side effect profile. I personally would not choose abemaciclib in this patient who's had a pulmonary embolism and her performance status is relatively poor, much probably owing to the fact that she is wheelchair bound. So she's high risk for VTE. But palbociclib or ribociclib would be equally appropriate, in my opinion, although ribociclib has demonstrated overall survival benefit here. So perhaps maybe a little more excitement or enthusiasm for that agent, although many of my colleagues would feel that either is perfectly appropriate.
Thank you for that. Dr. Buchholz, do you want to comment about the approach for radiation therapy in this patient for palliative treatment?
Sure. Palliative treatment for metastatic disease to bone and breast cancer is usually done for pain, but at times also for bony stability. And it's actually decreased in frequency quite a bit from when I first started due to the success in systemic treatment approaches for bone health and efficacy of hormonal therapy. But nonetheless, I think with a kid, it's highly effective in achievement of good palliation response. For someone with a poor prognosis, and particularly these sites where there's not a lot of critical normal tissue next to femurs and shoulders, et cetera, it's quite reasonable actually to treat them with a single fraction. It's much more cost effective, less expensive, and been shown in trials to be equally effective at achieving the palliative endpoints. So that's the only consideration. It might be hard for someone in a wheelchair with difficult performance status to actually lie on the table to get all the planning and things. So you could even treat a single fraction in 3 consecutive days and just bring her back, and you still decrease her overall treatment time by 70% that way.
Perfect. Thank you so much.